All right, let's get started. Good timing. Okay. Diving into week 2. This is still musculoskeletal. If you hate musculoskeletal, good news next week. Moving on to other stuff. A little bit of musculoskeletal next week. I won't be here, but I think Vernadeth is doing it, Dr. Alarcon. When you flip the body over next week, you'll be on the front. You'll take the anterior chest wall off. That will involve some of that musculature we already talked about in passing briefly. Pec major, pec minor, those muscles that attach onto the axial skeleton from the front. But you'll remove those, you'll take the chest wall off. Today, we want to kind of bridge the gap a little bit. This is a little bit different than last week. Last week was very much dominated by muscles. Latissimus dorsi, where's it originate and attach? What's its innervation? What's its action? Trapezius, get through the layers. Now we're down to the rector spinae. Now we're down to the transversospinalis. Today, this is more about osteology, the spine itself. What does the spine look like? What does the spinal cord look like? And hopefully by the end of the day, you'll be inside the spinal column and be able to see the spinal cord. But there is this little bit of leftover. However far you didn't get last week, you need to finish some of that so that you can be ready to do the main thing today, which is the laminectomy, cutting the spinal column open, removing the back part of the spinal column so we can see down into the vertebral column where the spinal cord runs. That will also involve then, some of you will be doing that. At the same time, some people can be working up doing the suboccipital triangle, which I'll touch on real briefly right before we hand over to Mike and Bailey for the lab presentation in about 30 minutes or so. Before we get there, though, I want to talk through some of this osteology, some of the highlights about what do we do with this? What does it mean? Let's see, the pointer's still not. Let me see what works here. Okay, there. Okay, let's talk about the spine as a group. So we have these vertebral segments that all stack up like a Jenga tower, balanced on top of each other, held together with a lot of this muscular that we talked about last week, the transversospinalis. We've got rotatorus connecting from one vertebra to the one next to it and the one next to it. And then we've got multifidus running 2 to 4 and connecting those. So we've got some very local stabilization through rotatorus muscle. We've got some expanded local stabilization through multifidus, and then semispinalis longer distances. But we can see how no matter where we're at in the spinal cord, there's communication, control, stabilization between nearby vertebra, as well as expanding that out, so that the vertebra as a whole isn't this just stacked up fragile tower. It's more like a robotic snake arm that can kind of move depending on what muscles activate, and so we can get localized movement in one segment or in the segment as a whole. On the whole, then, we have this spine that looks like this on the right. I think this still works. Yeah. Okay, so on the whole, we have the spinal column in an adult, bipedal, upright, standing adult that looks like this. The issue here, though, is that when we're born, we have a completely flexion-curved spinal column. And so the primary curvature of the spinal column is considered to be kyphotic, or in that forward direction. Baby spinal cord looks like this, and it develops these other curves that are lordotic, going the other direction secondarily. So if we look at a baby and we compare a human baby to an animal baby, like we watch some Discovery Channel out on the plains of the Serengeti, and the little baby giraffe comes out, and after a few minutes it wobbles up onto its little toothpick legs and it can barely stand. But within a little bit of time, it's running off across the plain with its mom, or else a lion's gonna come eat it, right? A human baby doesn't come out and then struggle itself up onto its legs and have its ability to walk. There's a lot of reasons for that. One, they have gigantic heads, right, relative to their bodies. So there's some issues there. They don't have musculoskeletal control in their brains yet. One of the things that we don't think about too much is this shape of this spine makes it so that the center of mass is located very far anteriorly, because we're talking about, if you take a pure, like a donut, where's the center of mass of a donut? It's actually in the hole in the middle. It's not in the mass, right? Same with the letter C. If I have a thing that's shaped like the letter C, the center of mass is actually out here in space. And so the same, not to that extent, but similarly, because we have these flexion curved spines that haven't developed the lordotic secondary curves, baby center mass is very far forward. So even if they could do all the other things, like control their motion, their muscles, they'd have a hard time standing up because their giant heads and their flexion curved spines would make them fall forward, right? So what do? We take the baby, and after it's a few months old, we flip them over on their tummy and make them do tummy time. And they lay there and they flail around for a while, but eventually they realize, okay, this isn't so bad, and they start to lift their head up for a few seconds at a time. Then they get tired, and they do it again and again. And eventually they spend more and more time like this, and that is the motion that encourages the development of this secondary lordotic curve in their spine as you spend time on your stomach lifting your head up, right? What's the next step? Well, now that baby that's on their stomach starts to get their arms under them and push themselves up onto their elbows. And then the same thing is happening then in their lower back, because that's where that motion is occurring when they start to push themselves up on their back, on their elbows. You're getting that lordotic lower lumbar curve to occur. So you can see why developmentally we consider these secondary curves and why they develop. They're just part of the normal development of the things we do when we go from newborn to toddler, let's say. And then eventually you have this secondarily curved, multiple curved spine as a toddler that can accommodate a center of mass that's right in line with that spinal column. And now I can pull myself up on the coffee table and stand there because my center of mass is right over top of where my feet are. And eventually I let go, and then eventually I'm walking across the room. Okay, so developmentally, the shape of our spinal cord happens as we go through normal activity as a baby. When we look at things that prevent that, not even pathology, but just environmental things that prevent that normal development, take a baby that, actually 2 of my kids are internationally adopted, spent significant amount of time before I brought them home in another country orphanage. Those kids spend a lot of time just laying in a crib, right? And so there's a variety of things that causes, and some of the things that can cause is flat heads from laying in one spot too long and things like that, positional plagiocephaly. But here's another thing. Some of these developmental things about the spine can be altered whenever environmental conditions don't allow us to do what we would normally do. Eventually, though, we hope that that baby becomes a toddler, becomes an adolescent, becomes an adult that has some level of posture that when they stand up looks pretty normal. And in a textbook, we put a picture up like this and call it standard posture. And they have this guy standing there with the plumb line drawn down through them, through these landmarks that we would say is like perfect posture. How many people in here think that if you stood up here, if I hung a plumb line and stood you up next to that your normal posture would look like this? Not many, right? We all have this and this and this. You know, we all have all these things that don't look like this. And in fact, you know this because if I were to stand you up here with a plumb line and then like trigger you, like, okay, put those shoulders back, put your hips forward, you'd feel like you were standing really weird because you're like, I don't stand like that to get to that, right? So, is this what we should be shooting for? That's the question, right? You're going to find this out in life in general, particularly in medicine. I talk about this because I teach a lot of biomechanics of gait to students. We always talk about this thing like, well, what's normal? What's like the normal way to walk? Well, the moment we use that word, we're opening a can of worms. So same here. So should we shoot for this? Okay, let's just say there's an error. There's a set of error bars, right? There's a range of error that you're not right on that line. You're a little above or below on some of these, but as long as you're not too far outside that range, your body still probably functions pretty normally. So let's talk about some of the abnormalities. Under normal conditions, here's some of the things we look for. Lordosis. There's a lordotic curve secondarily at the cervical spine. There's a lordotic curve in the lumbar spine. Most often when we see abnormality lordotically, it's in the lumbar spine, more so than in the cervical spine. But what's that look like? Well, what's normal? Well, normal is something about 30 degrees from horizontal. What does that mean? That means if I take a plane and I pass it through my ASISs and my PSISs, like straight through there, it shouldn't be parallel to the ground because I'd have to go like this to get my ASIS and PSIS level with each other and parallel to the ground. Standing normally, that's about 30 degrees forward of parallel to the ground. So tilted anteriorly, anterior tilt up to about 30 degrees. If it's much less than that, if it's getting close to zero, then that's a problem. If it's much over that, then that's a problem. So if you're in this range, we'd say, okay, that's normal lordotic curve. There's a bunch of people, you've seen them, and it stands out to you when somebody has that excessive lordosis. Looks like their butt sticks out. It looks like their stomach's way forward. It really looks like their low back is very arched in a way that appears abnormal to you. What's the causes of this? Things like lax abdominal muscles, weakness here that allows forward movement, particularly because you're going to see in MD3, no, you're going to see it in MD4. When you go through the abdominal wall, through the viscera, you move the abdominal viscera out of the way, and you get so far through that you're looking at the back, like where we were, you're looking at it except from the front, you're going to see psoas, iliopsoas, the main hip flexor muscle. It attaches onto the lumbar vertebra. It attaches to the femur right here, but it attaches up here onto the lumbar vertebra. So how many people in here have tight hip flexors? Every single person. Why? Because in Western culture, we spend a ton of time sitting like this, and our hip flexors are in a shortened position. We spend so much time sitting and not enough time going like this and stretching our hip flexors. So we all have tight hip flexors, meaning that hip flexor is pulling, when I'm standing and try to stand up straight, that tight hip flexor is pulling my lumbar vertebra forward. And if my abdominals don't counteract that adequately, then what happens? That anterior tilt goes forward of 30 degrees. So these are some of the mechanical things that cause all of us to end up as we skeletally develop and reach maturity, and we've suddenly got, especially in women, because of hip and pelvic shape and girth and things like that, we see this really kind of lordotic curve. Some imbalances between quad and hamstring can contribute to that as well. And then lastly, weight is on there, right? We all know the lordotic curve that we see in a lot of pregnant women or in a lot of beer belly middle-aged men, right? That excessive anterior weight that pulls forward in a way that the pelvic muscles don't stabilize adequately and you get that anterior tilt. Can be transitory, like in pregnancy a lot of times with, appropriate post-pregnancy recovery and exercise and things like that. It may revert, but in the case of the guy who's had a big giant beer belly for 30 years, you've got actual morphologic changes in a way that now you get permanent changes happen. The opposite of that, we don't see it as much, except probably typically in a compensatory manner, is when we see the excessive kyphotic posture in the thoracic region. Sometimes, often, that excessive kyphotic arch can be in response to lordotic excesses that would, because if I just do an excessive lordotic arch, that brings curve, that brings my center of mass forward and I am off balance. And so compensatorily, we see changes as well. There are some other conditions, though, that can kind of affect how we shape our upper body. Some of those are postural relative to seated posture and things that we do environmentally, spending time, at a keyboard with the arms forward, things like that. And there's some other, then these have names, like anything else. If you spend any, and I just gave a few examples. We may use the term like sway back for the increased lordosis and kyphosis. So I have increased lordosis, and as a result, then I develop a compensatory kyphosis, and we may call that sway back. The one that can be more problematic is flat back, where instead of, it's not as common, but when you see it clinically, you should pay attention to it because it can cause all kinds of downstream effects, is somebody with flat back. Meaning if I look at their lordotic curve, and instead of being forward of 30 degrees, they're like nearly zero. And you can see what happens if I just put my hand into my lordotic curve here and I just purposely posterior tilt, and this flattens out. You can tell I'm doing it purposely, but there's plenty of people that you'll encounter that when they're just standing normal, they've got a very flat lumbar kind of just alignment. That can be problematic. So that one is one to pay attention to as you think about how some of these manifest. I think I got one more picture. Yeah. This just gives you then kind of across the spectrum. Some, like these are named, and if you end up in orthopedics, if you end up in PM&R, some of these things that kind of deal clinically with these musculoskeletal conditions, you'll come across this more. Now, let's contrast that. Up to this point, everything we've been talking about has been in what plane, posturally? Sagittal plane. Scoliosis, when I was in, I don't know, 4th grade, I remember PE class, the school nurse came in, had everybody bend down, look, and she looked down our spines to see if there was this abnormality in our spine. Because there should not be a curve when I do this and I look down the spine. What plane is that? That's frontal plane. If there's this, if it's doing the snake as I look down your spine when you bend over in front of me, that's a frontal plane deviation. Everything else we've been talking about is sagittal plane deviation. We should have this curve that looks like an S in the sagittal plane. We should not have a curve that looks like anything. It should be a straight line within the error bars in the frontal plane. And when we don't, this is generically what we call scoliosis, right? The interesting thing here is when we start to contrast causes of frontal plane postural deviations versus sagittal plane deviations. These frontal plane deviations, when somebody has scoliosis, the majority of the time, these are anatomical morphologic. Things like malformations, here's a few examples of vertebral segmentation during embryologic development can be a thing. It can also be then differences in musculature development, can be pathologic, genetic, whatever, in a way that causes what I would call a true anatomic morphologic abnormality that leads to a frontal plane deviation. And we say, okay, that person has scoliosis. Plenty of kids have very mild amounts of it that we say this will never affect you, and then plenty of people far on the end have a level that just seeing them walk, you can tell. We occasionally have one of our donors, one of the bodies that is dissected by all of you guys, who has a very severe scoliosis. So, we see these more severe cases as well. There's various, that bullet there, various congenital causes can lead to this. If we go back to this one, what do you think the primary cause of sagittal plane abnormality? Not looking like the guy on the previous picture with the standard perfect posture. Of the things that we kind of talked about, what do you think is the primary cause of sagittal plane abnormalities? Even barely within the error bars or outside the error bars? What is it?
Postural habit.
Poor postural habit. Because what happens over time? I'm in 3rd grade, and my teacher keeps getting on me because I'm sitting like this. Sit up, or your mom, stand up straight. Over time, I spend enough time like this, or however, that on each side of the joint, one set of muscles start to get shorter and the other starts to learn a resting length that's longer, and then suddenly that becomes my morphology. But did I ever have a true anatomical deficit? No. Was there a genetic cause underlying it? No. These are morphological adaptations that take place because of poor postural habit. Versus, did we even mention poor postural habit for scoliosis? I'm not saying nobody ever ends up with poor postural habit, or I'm not saying nobody ever ends up with scoliosis due to poor postural habit, but that's not really the cause of it in general, right? So when we think about these two, frontal plane versus sagittal plane posture, there's definitely a deviation or a difference there in what we should think about the causes underlying it, the etiology. Okay. As we think about the spine, one of the things in the lecture and in any reading or anything you look at, they'll talk about each of the vertebrae and how it's important to make sure you understand. I talked about it in the recorded lecture. I'm not going to talk about it here. What is a typical cervical vertebra versus a typical thoracic vertebra versus a typical lumbar versus a typical sacral coccygeal look like? They all have differences. Their spinous and transverse processes are different. The size of the bodies are different. Some of them will have certain holes that other ones don't. So it's important that you kind of digest that as you listen to the lecture and read some stuff. So that's important. But the one thing I want to jump ahead to, and I won't cover that right now again, it's all in the lecture, is thinking about the disc. Because when we think about pathology of the back related to this spinal column, we're really talking very often about disc pathology and how that affects spinal column, spinal cord, spinal nerve root pathology. So here's the disc. What does a disc look like? Let's jump ahead to this. Sorry, we'll come back to that slide. This describes the anatomy of the intervertebral disc. We have intervertebral discs, not between every, sorry, which did, oh, I didn't put it on there. Okay. How many vertebrae I got?
33.
Okay. So how many intervertebral spaces is that? 32. But how many intervertebral discs do I have? 23. So why not 32? Well, the sacral and coccygeal are fused. So those aren't intervertebral spaces with discs. But that would still only bring me down to 24. Where's the last one? C1, C2 doesn't have an intervertebral disc. But everybody else does. And it looks like this with some variation. You've got this area in the middle that's gelatinous, that's shock-absorbing tissue that we call the nucleus pulposus, with a fibrous outer layer that is multiple layers. And this is really cool. I love the way that's drawn on that upper left picture, and they start to pull the layers off. Those corresponding layers are at 90 degrees to each other, so they're interlaced fibrously, and it just really accentuates kind of how strong that outer layer is. Now, why do we have both? I understand the nucleus pulposus. A big role of those discs is when I load my vertebral column and two vertebrae would want to bang into each other bone on bone. That thing serves as a shock absorber, like putting a big old thick Dr. Scholl's insert into your shoe that's nice and foamy. I can step down, feels nice and soft and spongy, right? Same thing. The problem is, without that nucleus pulposus, basically you have the equivalent of a jelly donut between the two vertebrae. And if I took a jelly donut and I took two books and I smashed it down, the jelly donut explodes and the jelly comes out the sides. But if before I slam down the jelly donut between the two books, I take duct tape and I wrap it around the outside of the jelly donut to hold the jelly in, then when I push down, the jelly tries to expand out and absorb, and the outer layer of duct tape, annulus fibrosus, serves as a maintaining integrity of the intervertebral disc. So we've got this nice structure here that varies a little bit from vertebral level to vertebral level in a way that allows the nucleus pulposus to be right down closer to that center line of standard posture, depending on the shape. So in the thoracic, where the line of load is a little bit forward, the nucleus pulposi, I don't even know if that's plural, the nucleal pulposuses are a little further forward, and then in the lumbar regions, where that line is a little bit back, then the nucleus pulposus is back a little bit. So it's a very functional, nice thing that's going on here. The problem occurs is that over time, these are 6 degree of freedom motion enabled, meaning they can take all 3 planar movements to allow vertebrae to slide in all 3 directions relative to each other, but then they also can allow twisting around all 3 axes. That's what all 6 degrees of freedom is. So they're freely mobile, not a lot of range of motion, but mobile. But the thing that happens is, if we look at one of the things from the lecture that you should remember, if I had the vertebra here and the lamina and arch here, if I just look at the vertebral bodies and I have 2 vertebral bodies or multiple vertebral bodies stacked on top of each other, I have 2 ligaments that help hold. This is the anterior ligament, and here's the posterior vertebral ligament. The anterior ligament is very broad and strong. So this is further reinforcing the duct tape around the jelly donut in the front, but in the back, this is narrow and thin and not that strong. Because remember, I'm switching planes on you here. When we have this going on, and this comes out the side, dorsal root ganglia, this is coming out like here on each side. So I can't have complete ligamented, because this is running all the way up and all the way down the columns. So this can only be so wide so it doesn't hit the nerve root or provide room for the nerve root. And also the arch is here, right? The spinal cord is in here. What that means is the jelly donut duct tape is least strong in those areas. Nice and strong in front, little bit of support in the back, but not as much. And outside of that narrow band, from here around and from here around, I only have the annulus fibrosus. As just a matter of course, as we age, loading causes degradation of those vertebral discs, those intervertebral discs. And now I get in a situation when you're older, just because you're not using this, can I use this real quick? I've got a vertebral body and a vertebral body. And I've got on that next, they use the ball, like a water balloon in between them, right? Showing the 6 degrees of freedom. If I recreate that here with 2 flat surfaces that are my vertebral bodies, if I go and I push straight down on this, there's pretty much equal chance that it'll burst in any direction, right? If I tilt this like this and I push on the water balloon, the odds of me getting wet are low. The odds of him getting wet are high because I'm applying a lot of force back here, pushing it forward, and when it bursts, it's going to go that way, right? So the same thing occurs as we age, and now I go to pick something up, and I take me picking something up is loading the 2 vertebrae relative to each other. And if I pick it up in a way that takes the 2 vertebral bodies from this to this instead, and I apply all this pressure onto one, either the front or back surface of the disc, then the opposite is at risk for blowout, literally, of the annulus fibrosus. Nucleus pulposus wants to push out through the duct tape. Well, where is that most a problem? from a morphologic standpoint, it's back here. It's these back corners. And that also couples with what we tend to do. We tend to, now this is me facing you, so this is front. I tend to bend over and pick something up. And then when I pick it up, the front of the vertebral disc is being loaded, meaning more pressure backwards toward the area that's naturally weak anyways. And so this is why. Where do I herniate discs? Do I ever herniate discs forward? Short of some really bizarre, weird situation, no. I don't even herniate discs laterally, really. I always herniate discs posterior laterally, not straight posteriorly, because that little bit of ligament is there, so it's going to weaken and bulge one side or the other, and that makes sense. This is also why, what do you do with something heavy? Lift with your legs. Because why? Not because just because my legs are stronger than my back, but because this keeps my vertebral bodies like this, and the pressure is more consistent on the intervertebral disc. As soon as I go like this and lift, now I'm putting the pressure on the front of the disc toward the back, and if I have weakening of the annulus fibrosus, I increase my risk for cervical disc herniation. When that occurs, what's there? When it pushes back into that space, what's there? Not the spinal cord. The spinal cord is midline. It's sitting right behind this posterior longitudinal ligament, so it's pretty safe. But you're going to see when you take the laminectomy and take the vertebral column apart and cut through the dura and actually see the spinal cord, and you'll see this anterior and post. This is the posterior nerve, or the dorsal root and the ventral root. You're going to see both of those, and you'll see that they come out and down through the intervertebral foramen to go out to the body. They're right where those discs shoot out. And so that's what's being shown right here. This is the spinal nerve root here and here. This is like the spinal cord proper, and then here's the roots coming off from the level above, a couple levels above, right? So this is what's getting compressed, damaged, at risk whenever we talk about intervertebral disc herniations. That's kind of the mechanism behind, most commonly, L4, L5, L5, S1. Lumbar, the lumbar nature of our vertebra already put us in a position where we're already in that kind of forward flexed position. So we're putting pressure on the back of the vertebra just based on, over our lifetime, a lot of the weight. The entire body weight is kind of sitting down on L5 onto the sacrum. When you see that sacral promontory there, where the L5 comes down onto the sacrum, it sits at a really big angle. So this force here means your lower lumbar are taking a lot of force throughout your life. And what does this look like? Well, any nerve root compression looks like neurologic radicular symptoms. What does that mean? Shooting pain, numbness, weakness, tingling, temperature, feeling hot down the extremity. Vast majority of the time that I've seen clinically, those are lumbar. I've had a few cases, wrestlers mostly, that have cervical disc herniations, and then you get upper extremity distributions in that case. But mostly it's lower lumbar disc herniations that lead to these symptoms. Okay. Couple comments then about the types of injuries we see to spinal columns and spinal cords. This is a good example. In the cervical region, there's kind of two things that we think about. We can apply this to sports. Competitively, we can apply this to like recreational daily life activities. I'll use the football example because it's easiest. There's kind of two categories here. This is our first one that we worry a lot about, and that is axial loading of the spinal column. If I have a normal spinal column that has this cervical lordosis, thoracic kyphosis, lumbar lordosis into the sacrum, then up in this cervical region, I've got this bend here combined with this bend here that makes this thing very much like a spring, right? So as it absorbs, you can get more kind of bending in a way that acts very spring-like. The moment I take this vertebral column and at any place in this vertebral column let's say I did this. Let's pretend that's exactly the same. But once I got down here, I flatten this out. Instead of having this nice lumbar lordosis, I have a flat back. And so all these vertebrae are lined up on top of each other. That's a problem. If it happened up here and instead I had a cervical flattening, and all of these are lined up on each other. This is a problem because now the loadings that occur can't give like a spring, but instead they do like that thing when you see a martial arts exposition and the guy has bricks stacked up and he hits the top one and the force transmits down and blows out the one at the bottom, right? That's axial loading, loading along one single axis. And when we see this in the cervical vertebra in particular, it's particularly dangerous. So when do we see that in cervical vertebra? What's that look like in football? I always ask this so you guys can chuckle at each other. Who's my high school football players here? One? A very unathletic group this year. Oh, two.
I never led with my helmet.
You never led with your helmet?
Yeah.
Right.
Better.
Right. When is this a problem? When we lead with our helmet. Okay, you didn't play, but you're a college or NFL football fan, especially if you're a college football fan. You guys are disappointing me. I know I'm spending too much time studying. I don't have time to watch football. College football in particular, a point of emphasis for the last 10 years has been not being able to stick your helmet into somebody. You'll get a penalty and get thrown out of the game for it. Because why? Because there are plenty of documented instances. One of them, I wasn't there on the sideline. This was after I left Ohio State. I did my undergraduate training in athletic training at Ohio State, worked football. This was a few years after I was gone. A freshman from Penn State playing at Ohio Stadium came around the end on a kick return and went to tackle somebody, put his head in, and basically was lucky that he walked ever again. Like he was quadriplegic. They're like, he'll never walk again. He was able to walk across the stage a few years later and get his diploma. But that was just from going in to tackle a punt return or a kick return and putting his head in like this, flattening out his cervical vertebra, axial load, and you end up, I think I've got the picture here. This is a blowout fracture at the bottom of the cervical vertebra from an axial load. Like the karate demonstration, you load the energy down through. There's nowhere for it to absorb until it gets to a weak point, and then it blows out the cervical vertebra. Yeah, it blows out the cervical vertebra. These people end up paralyzed. This is what happens when the person dives into a shallow area, right? You stick your head forward, you take the curve out, you load yours onto your head, and you break your neck through an axial loading of the spinal column. Okay? The other alternative, this is always interesting because the alternative is I keep my head up. And if I get hit hard enough, even though I have my head up, then my head gets pushed back into extension too far. Then I think I mentioned this in the recorded lecture, the connection, this is the atlas, the ring. Spend some time looking at the bone box vertebra and looking at especially atlas and axis. They look so different than the rest. Atlas sits onto the dens, the odontoid process of axis, and it rotates around it, but it's not freely doing that. There's a bunch of connective tissue to hold them relative to each other because we can't have this occurring. If this occurs, then my spinal cord gets shredded. So your body has worked very hard to make sure that den sticks right up against the notch and the atlas, and it's got connective tissue across it. So much connective tissue so that if I get forced into hyperflexion hard enough, before those ligaments that hold it there tear, the dens will snap off. That's how strong the ligaments holding that atlas up against the dens are. And we see this, a hyperflexion injury from that same thing. I can't hit here, I actually load. I can't be here and get overpowered, snap my neck back. And it's very uncommon, but that is what does happen with an extreme hyperextension injury. It'll actually snap the dens off of the atlas. Or axis, sorry.
Are they paralyzed after that? Or?
It kind of varies. It kind of varies in terms of secondary, because any injury then to the spinal cord is secondary. Right? I want to talk about a couple other small things here before we get over to the video for the lab. Those are more like acute traumatic injuries that you might see from a car accident, from athletic activity, even recreational activity. People break their necks skiing and things like that, right? Enough force creates enough trauma to the bone. This is This, though, when we think about the vertebra, is more something to be aware of relative to those of you in primary care who are going to see people coming in with aches and pains from physical activity, adolescents, teenagers, from sports activity, whatever the case may be. If I look at the shape of the vertebra here, roughly, the body, the arch, and the lamina, and the transverse processes and the spinous process creating the vertebral column, anytime I go into full extension of my back, I mentioned in the recorded video, I spent some time talking about the zygapophyseal joint, called in kind of, you'll never hear a clinician say that. It's an anatomical term. What is that in clinical terms? What do we call that? Facet joint. We talk facet, F-A-C-E-T. Say that all the time clinically, the facet joint. It's the zygapophyseal joint. It's the superior interarticular process and the inferior articular process of two adjacent vertebrae that butt up against each other and literally serve like you pulling into a parking spot and hitting the block so you don't run into the fence. That's how they serve on the vertebrae to prevent them from going too far. You should get bone, not really bone on bone because they're synovial joints, so they have articular cartilage, but it's meant to be a bony stop, a hard physical stop that prevents two vertebrae from going too far. But when that does happen and they do bang into each other and they slam the car into the block, there's some force on the block, and eventually you do that enough and it might scoot the block when you pull in. Same thing here, when I'm pushing through repeated extension, that force is being transmitted into the pars interarticularis, this part of the arch. This is in the wrong plane, so I can't draw it real well, but just it's being forced onto part of the arch. That over time can lead to what, for all intents and purposes, is a stress fracture of the pars interarticularis. The pars interarticularis here is one that's snapped through. But even before it gets there, this arch that's being pushed on and transmitting force from the parking blocks running into each other leads to a stress fracture. What is a stress fracture? By definition, a stress fracture is when osteoclastic activity outpaces osteoblastic activity. That's just a fancy way of saying whenever I load bone, loading it causes some breakdown of tissues and then resting it causes them to rebuild. And if the rebuilding outpaces the breakdown, then my bones get stronger. And if it's the other way around because I load them too much and I don't rest enough, then the bones get weaker. And if I'm a runner that runs and I get shin pain because the osteoclastic activity is outpacing the buildup of the bone, I'm not resting enough, then eventually I get a stress fracture in my tibia. Well, the same thing happens here. The same thing happens when you take a paper clip and straighten it out and you bend it once and it doesn't break. And you bend it again and it doesn't break. And 3 more times, eventually it breaks. No single bend and the damage you did to the metal from one bend was enough to break it. Well, additively, it ended up weakening it to the point that it broke. So the person comes in with this pain during extension, especially in the low back, especially when they do this thing called a stork stand. Hop up here real quick, Lauder. We'll just do it real quick. Face that way.
Okay.
I stabilize him. I put my hands on his PSIS. He's got this pain, not midline on the spinous process, just to the side. I've got some other history. I suspect, okay, maybe he's dealing with spondylolysis. I take that foot, go ahead and stork stand on this leg.
Okay.
Yeah, stork stand on this leg and just... I'll help you balance. Bring your foot up a little bit so you're like, more like a stork. Bring your foot up off the ground. There you go. Now lean back and try to look at the ceiling. I'm going to make sure you don't fall. When he gets into this position, think about what's happened. That's good. Don't fall on me. Okay, that's good. Stand up. But when that's good. You're good. You're good. When he's in that position, what are the facets doing? I'm really accentuating that bend and force them into each other. So I'm loading that pars interarticularis in a way that if he has a stress fracture, to an extent, it'll show up clinically. What's that show up like on imaging? Probably doesn't show up on an X-ray at that point, but it'll show up on a bone scan. If you do a bone scan, inject the dye, follow it up, do a bone scan, you'll see a black line right across the pars interarticularis. That's a stress fracture. That's a spondylolysis. Olysis, abnormal condition of the spondylolysis. Okay. When that gets bad enough and snaps clear through, we call that a spondylolisthesis, the one after the dash, spondylolisthesis. When it snaps, it was a stress fracture. It was the paper clip that was getting weak from bending it, and eventually it breaks. You'll see this if you deal with kind of, sorry, Mike, I know you're listening. I'm almost done. Okay. Today, when you take it apart, I want you to see some structures of the spinal cord, not just the spine itself. One of the important structures is conus medullaris becoming cauda equina. Cauda equina is where the spinal cord proper ends and just becomes nerve roots, and cauda equina means horse's tail. It just looks like a tail of an animal, strands, right? Where does this typically occur? Do you remember from the reading or the lecture? Huh? About L1, L2. Okay, so normally cauda equina starts at about L1, L2. Conus medullaris ends, cauda equina begins. There it is drawn out, kind of at that L2 level. Below that, we just have the dural sac is still there, but we just have strands of nerve root. Okay, so then when we give epidurals, when we need to puncture the dural sac for any number of reasons, the most common ones would be taking a spinal tap to test for meningitis, also epidurals during childbirth, right? Those are probably the two most common to think of. Where do we do that at? Well, we need to be below L2. We typically do this in the L3, L4 space or L4, L5 space, because the goal is then, look at this today when you take that apart and look at it, the cauda equina down there, it's like then I'm sticking a needle in, and if I had a broom up here, and I gave you a needle and I said, stick this needle into the handle, you'd have no problem. You stick the needle into the handle. If I try to stick a needle through the dural sac up here, the spinal cord is it's a structure like the broom handle, and I'll stick it through and I'll stick it right into the spinal cord, and that's really bad. But down here at the cauda equina, when I stick the needle through the dura and it's now in the dural sac, that'd be like me telling you, okay, now stick the needle into one of the straws of the broom. Lift it up here, now stick it into one. Every time you stick the needle in, the straws would move out of the way and you'd just be punching the needle in between straws all day long. This is what's happening when we give an epidural. If we're low enough that we're in cauda equina, we stick the needle in and the nerve roots just move right out of the way and the needle goes right in between, and we don't end up sticking the needle into the actual nervous structure. That's why we do it there. Here's the one caveat. One of my former athletic training students years ago, her father was a longtime neurosurgeon, and he said, variations. He said, over my career, I've seen cauda equina that started mid-thoracic in some people. L2 is about where it's supposed to be, L1, L2. He said, I've seen people who are mid-thoracic. He said, I've seen people who never develop a cauda equina before it goes into the sacrum. It's just spinal cord, and then it goes all the way into the sacrum. Granted, those are the barrier cases. That's not the most common thing. But still, the point is human anatomical variation means, and he said, and everything in between, obviously, right? So there is some variation. When we say L1, L2, that means most of the time that's going to be the case. But you could go right now, and without much problem, you could find a case study on Google Scholar of an epidural injection that hit a spinal cord because the cauda equina hadn't started by the time it got to L3 or L4, right? So these variations do exist. And that's, when you sign the consent for, we're going to do an epidural, those things are on there, right? Those are the complications. Could include me sticking a needle into your spinal cord if you have non-normal anatomy. But that's just kind of the normal anatomical variants that occur. And that's why we put it in there anatomically. This is it. Last slide. Promise, Mike, this is the last slide. I just want you to just look at the top one for a minute. Just look at the top one, because this is the summary slide for how we think clinically about anatomical back. This is an older study, obviously, from 91. 66 asymptomatic patients examined with MRI. 18% had disc protrusion on the MRI, as read by the radiologist. 39 had a bulge of the disc that was significant enough to be associated with degenerative disc disease. In total, 57% showed disc changes, but all of them were asymptomatic. So what's that tell you? What's the clinical pearl there?
didn't like infiltrate the nerves.
It clearly wasn't infiltrating and pushing enough to push a nerve in a way that was creating symptoms, right? Zoom out a little more. Not all disc process of herniation. Herniation isn't a, I'm totally fine today, boom, it herniates and I have symptoms, right? That's why it's called degenerative disc disease. You start to show bulging. Some of you in this room, because of bad genetics, you're a few years older, you've done some activity in your life, something, some combination. If we MRI'd everybody in here, there probably, even at your relatively young ages, would be a couple people, even though you're symptomatic, have backs that a radiologist would be like, we gotta keep an eye on this, right? So the process of low back pathology is can be very, that arc can be very long and degenerative, right? Now look at last one here. Look at the second one. After a physical exam, now these are people who saw a clinician because of pain or symptoms. After a physical exam showed leg pain and neurological signs of nerve root compression, like positive Brzezinski-Koenig, straight leg raise, all these clinical tests we do that if they initiate numbness, tingling, we say, okay, that's a problem. After physical exam showed leg pain and neurologic signs, meaning your clinical differential would be, I'm worried about disc herniation. 50% of patients scheduled to have surgery had their diagnosis altered after an MRI did not confirm the impression of nerve root compression. So that's the opposite of the first one. And what's the take home from that?
You can have pain and neurological signs without any herniation.
Other things could be leading to symptoms that look like nerve disc herniation with nerve root compression. Take home pearl number one, differential diagnosis can be really, really hard, particularly in the back. Secondly, this took me forever to learn to teach myself clinically. I really thought, let's just get an image. And I had a very good mentoring team physician who was an orthopedist who was like, imaging is just one piece of the puzzle. Because there's a lot of stuff I've seen over my career that shows up on imaging that if I went off that, I'd be like, let's get into surgery. Then I start talking to him. This doesn't hurt, really? Are you sure? No, I'm fine. I'm not going to go in there and start cutting, right? So imaging is not the full answer. The clinical exam is not the full answer. It's a satellite of things we do to do differential diagnosis, and it's challenging. The last thing I'll say is this. When we put those epidurals in, anybody had an epidural done to them or seen an epidural done? How'd it go? Huh?
Terrible.
Terrible. What's above that? What do I have to go through to get it in there? When you were dissecting last week, right here, it's diamond shape and bright white. The thoracolumbar fascia, and the tables I was able to get around to, I showed you how thick that thoracolumbar fascia is. I could literally pick the body up by that thoracolumbar fascia. It is so stout, meaning you got to get a needle through there. And that stuff is so thick that I'd always heard that when you stick a needle through there in an epidural, it'll make an audible pop. So about 17 years ago now, I got the opportunity when my wife went into labor for the first time, and she was sitting there facing me, and they were getting ready to do the epidural, and I was like, could you stop? Be quiet. I didn't do that. But I did listen really close, and you can hear it pop, okay? So be ready for that one. That's an anatomical function of how thick that thoracolumbar fascia is, all right? Just as an aside. So if any of you meet my wife, your third year in Hilo, don't bring that They're going to talk you through this, the short version. Here's the short version. He's going to give you the long version. The short version is, make sure you have multifidus, make sure you can see multifidus, and you want to see rotatorus and semispinalis. You're going to make sure you have erector spinae reflected. Then you're going to do the laminectomy and get the saw. And there's some special instructions for using the saw. Otherwise, other people then can be working up here at the suboccipital triangle, and if I have 1 minute at the end, I will show you what this drawing of the suboccipital triangle, what everything is. If you don't already know. If you already read and looked at it, you should be able to interpret my drawing pretty easily. Mike, are you there? Can you full screen pin the top left one?
Oh no, I
Wait, that says no even. Oh, yeah. Mike, hello? We can hear you, okay. Hold on, guys.
Okay.
Listen, we can hear Mike if you be quiet.
Okay, I think he's saying go ahead.
Yeah, you guys keep going.
Okay, the first speaker is Bailey.
Okay.
She's gonna start.
Okay, so we're going to talk about the suboccipital region. And so just to orient you and to kind of refresh what we talked about last week, here, this is superior, this is inferior, as you can see. Okay, this is the back of the head. Let's go through the layers that we went over last week and that you should have dissected already. Okay, so this muscle here is the trapezius muscle. And so you should have that reflected. And then down here, you should see the rhomboid muscles, and then the serratus posterior superior. And then when you peel those back, this is your splenius muscle. So up in the back of the neck region, right underneath the trapezius is the splenius muscle. Down here, right, you have the rhomboids and the serratus posterior. Okay, so you should have reflected your splenius muscle as well. And what you should be seeing now, if we can zoom in on this area, you all probably have your semispinalis capitis still attached up here, okay? One thing that you'll see poking out of it, your semispinalis capitis, is your greater occipital nerve. And so that was kind of what we told you to look for last week. Directly underneath the splenius, you would see this muscle, semispinalis capitis. Okay, so the first thing that you're going to want to do is reflect semispinalis capitis. So it attaches right up here. It is relatively thick, but you're going to want to be careful, obviously, to not cut too deep because those muscles of the suboccipital triangle are deep to it. But I will say that they are pretty deep. So I think you have a little bit of room, but as always, put a probe underneath it before you cut it. If you could try to keep that connection of the greater occipital nerve, that would be awesome. But you'll reflect the semispinalis capitis. I will also say that as you're reflecting it, this is going to obviously not look as neat on your silent teacher. And so there's going to be a lot of adipose and some vessels that are all kind of in the space. And then there's going to be a fascia over these muscles. So you'll have to disconnect that and cut through that. But again, try and keep your greater occipital nerve. And yeah, make sure that you maintain these muscles underneath. Okay, so semispinalis capitis has been reflected here. And the next muscle that we're going to look for is directly deep to semispinalis capitis is semispinalis cervicis. And this is attaching to a really important landmark for today. This is the C2 spinous process right here. And you can feel that. It's pretty prominent. And semispinalis cervicis is going to connect to the C2 spinous process. Okay. Also coming off the C2 spinous process are a couple other muscles. So the first muscle that we're going to look at coming off of this spinous process is our obliquus capitis inferior. Okay, that's this muscle here, obliquus capitis inferior. That's going from the C2 spinous process to the C1 transverse process. And I hope you can appreciate how far over my probe is. And I'm touching the C1 transverse process. I'll show you the bones after I go through the muscles, but this transverse process of C1 is really, really wide. And so you should follow this laterally until you can palpate that. And it might even have to be with a probe. It can be pretty hard to reflect all of this. So that C1 transverse process is really lateral. So again, this is the obliquus capitis inferior muscle right here. The greater occipital nerve is going to come out from underneath of that muscle, as you can see. Okay. All right, now also coming off of the C1 transverse process is this muscle that goes to the base of the skull. This is the obliquus capitis superior, right here. Okay, that's going to be your lateral border here for our triangle. And sometimes it can be pretty lateral, so just make sure that you're reflecting these muscles as far as you can, and really try and use these landmarks like the C1 transverse process to help you identify where this is going to be attaching to. So again, this is the obliquus capitis superior, and this is obliquus capitis inferior. Okay, coming back to the center, the C2 spinous process that we've been talking about, there's another muscle that's coming off of it, and it's the rectus capitis posterior major. And that's this large muscle here, and that's going from the spinous process up a little bit at an angle to the base of the skull, okay? Rectus capitis posterior major. And then medial to that, and a bit deep, is rectus capitis posterior minor. And that's going to go and attach to the C1 spinous process. So that's rectus capitis posterior minor. And then just to go through all those muscles again, this is obliquus capitis inferior, obliquus capitis superior, rectus capitis posterior major, and rectus capitis posterior minor. Okay, the greater occipital nerve here, it's going to do sensory to the back of the head and motor to the semispinalis capitis. And then we have another nerve that you're going to want to find, and that's in this triangular space. So this is the space that you're going to want to be dissecting into. This is the suboccipital triangle space. And there is a nerve here, which is our suboccipital nerve. It's a little bit hard to see, but it's going to be in this space more on the lateral side. Okay. And this is going to do motor innervation to these muscles. And you can see how it's attaching to all of these muscles. Okay. And then the last thing in this space, the last thing in this space is going to be the vertebral artery. And so we actually don't get a good visual of the vertebral artery here because our silent teacher C1 is very, very large. But the vertebral artery is going to be deep here, right along the bone. It sits on the groove of the posterior arch of C1. And so that'll be right around where my probe is. And again, that'll be the deepest thing in the triangle, right? When you get to the bone there, and we'll show C1 in just a second, or yeah, if you want to grab it, that'd be great. So Michael put it in the camera for us. Yeah, so it's going to be right here. This is that groove.
Oh, can you do it
Yeah, can you flip it like this?
Point it like that. Point it first
Like that,
like
yeah.
that, and then
Yeah, so then this is what it's going to be like. Also, please appreciate how, lateral this transverse process goes. It's really wide. So keep that in mind for the obliquus capitis muscles. But the vertebral artery, you're going to see it right around here as it goes across. And again, we just weren't able to get a good visual for our silent teacher of that, but you all should hopefully be able to, but it should be right, right in that groove there.
just say the arch is big
Yeah,
here.
the arch is really big here, but it's much smaller, I think, traditionally. So you'll look for the vertebral artery there in this space here.
Okay, so we're gonna jump down towards the to the spinal column. I was gonna mention earlier when we jumped into this, for those that like puns, welcome back. Hopefully that you guys are bursting in laughter, probably not. But I'll go ahead and talk about the spinal column, but I want to take a step back real quick as a quick review as it leads into the things that we care about this week, which is that transversospinalis group, and then doing the laminectomy and appreciating the structures of the spinal cord itself. So if you haven't already, the I love spaghetti that we talked about last week, if you haven't separated and identified where are those margins for each of those muscles, then spend a little time doing that as soon as you get in, looking for that iliocostalis, that longissimus muscle, and then all the way up against the spinous process, the spinalis muscle. As you can see, it's been removed here, okay? Once you've done that, The next thing you're going to do, if you haven't, I think a few groups worked on this a little bit last week, is look for those 3 different muscles of the transverso spinalis. Now, starting most inferior in the lumbar region, what you can do is take a finger or a probe, and you have this very thick erector spinae aponeurosis that you want to try and get between that and the spinous processes. Okay, once you do that, you're going to take a scalpel and cut through this and detach it so that we can reflect it laterally. And when you reflect it most laterally, you should be able to separate nicely this muscle right here. This is our multifidus. Now, we always recommend looking for that multifidus muscle in the lumbar region because that's where it's most pronounced. Okay, we do have multifidus fibers up in the thoracic, but it's not going to be this pronounced. And so this is really the best area to appreciate that. Okay. And you guys have talked about that it's so enlarged that it creates that mammillary process. Okay. So do that. I'm going to move up superiorly. In the thoracic region, the muscle of the transverso spinalis group that is most pronounced is, or has its most pronounced fibers, is the rotatories muscle. Now we're pretty deep. I'm flipping back some of these fibers of the erector spinae. Normally, this is the first time I've seen fibers this pronounced, and so your success or your ability to really appreciate this, you may experience a little bit more challenges really trying to differentiate. But one of the things you can use is as you palpate, you feel this transverse process right here, and you see fibers going 1 to 2 levels upwards. Okay. And so rotatories sitting all the way up against that lamina, going from the transverse process to the spinous process, has a, I'm going to try and pinch it here, right? A rotatories brevis, and which goes 1 level up, and a rotatories longus, which goes 2 levels up. Okay. I also just want to quickly point out that right here, this is going it's ascending much more than 1 to 2 levels. And so this is likely a tendon of the semispinalis muscle, okay, which I won't spend much time, but just real quickly pointing it out, we already looked at, Bailey showed the semispinalis capitis and the semispinalis cervicis superiorly, the last of the 3. And those fibers typically will span 5 or more spinal segments up, okay? All right, so let's, once you've done that, you're going to raise your hand or get a faculty member and say that you're ready to do the laminectomy. We will come around, or in advance, Dr. Alarcon will assign a section of the spine that you will do the laminectomy
No
at.
more sign me.
No more sign.
Yeah, we're
Okay.
just going to do mid-thorax to L3.
Perfect. All right, so you will do, so everyone will do, this is breaking news, guys. You're going to do mid-thorax to around the L3 region. You might be saying, well, how do I know that? You're going to palpate the spinous process from the pelvis, and you sort of estimate, try and feel to your best knowledge where that L3 is, okay? But in order to do that, you'll call us and we'll check to make sure.
And also, Mike, what they're going to do anyway is once they start, they're going to clean up the gutter.
Right.
And then they can really count base,
Right.
transverse process.
Right. Yeah, I'm just gonna mention that next.
Yeah. Okay.
Yeah, so call us over, and then we'll help you. What you can do is in order to do the laminectomy well, you want to remove all of these gutter muscles off of that section. And so I know you've spent a little bit of time dissecting it. It's unfortunate, but we have to cut those muscles out of the way so that we can identify where the lamina is. And we use palpation of those transverse process to help us clear out that whole section. And you'll take a scalpel and you'll cut it off, you'll remove it, or you'll scrape it out of the side, either using a chisel, so we can get a good idea of where we're cutting. Okay. Now, after you've done that, actually for groups where you know that your silent teacher maybe has a little bit of osteoporosis, it may be enough to just use a hammer and chisel, in which you're placing the chisel on the lamina, and then you're hammering in little by little until you feel you've gone all the way through. Don't just hammer as hard as you can all the way through, because there are some structures that I'll show in a minute that you want to cut. And you're going to do that all the way along on each side, and then through that interspinous ligament, top and bottom. Okay. Now, for those that maybe you haven't noticed an apparent osteoporosis, you'll get one of us, and Steve will help you use the bone saw to make those cuts. Okay, and he'll teach you. We usually go at a 45 angle, and he'll walk you through that process. But for saving you a little bit of time, I'm gonna move on. Okay, real quickly to show you. Hold on, let me pull this glove off. Right, so this is obviously not lumbar. We're up here in the cervical and just starting in the thoracic region. Oh,
Yeah.
Here we go.
Yeah.
Perfect. Okay, here's the lamina, right? And so essentially you're breaking just medial to that transverse process, and you're going to remove it with the spinous process attached, right? You use some pliers, and eventually what you should get is something that looks similar to this. Okay. Just want to point out and reiterate for you to appreciate this while you're dissecting. Dr. Stickley talked about epidurals and collecting CSF fluid through lumbar punctures. And so when you remove this piece, you can get a good look at that interspinous ligament right here that the needle's going to go through. And then turning it over between each lamina, you'll see a yellowish ligament between ascending between each lamina, and that's your ligamentum flava. Okay, usually has a yellowish hue or color to it.
Looks good.
Okay, all right, so we're almost there. Let's real quickly talk about the spinal cord. I'm putting my probe in. Pretend I've peeled back and pinned it open, but I'm going to push this back. Now we're in this epidural space, right, on top of the dura. So we're not quite in yet. That should be the first thing you see. There may be some fat and stuff that you need to remove, but it should be pretty apparent pretty quickly, okay? And one thing I want to point out is we see these nerves.
Can you sharpen it a bit more? Yep, it's sharp. Yep.
Extending out laterally. Okay. Now these are dorsal nerve roots. If I flip this over, you see some of the nerve roots going lateral that are piercing the dura. This is the dura mater. And becoming or continuing out of the intervertebral foramen, but I see this little bump. What is this little bump right here? Okay. This little bulge is the dorsal root ganglion. And that's the collection of those pseudo-unipolar neurons. Okay. So take a little time before you just go straight into cutting the dura to look for that dorsal root ganglion, right? And you have both sides. And that's why we don't want to just chisel all the way through, because inevitably what happens is you cut right through those, okay? All right, so I already mentioned this. I kind of skipped over it, but here's our first layer of the meninges, the dura mater, right? It's going to be closed. You're going to take a pair of forceps, lift it up, and then take a scalpel and sort of cut down with the tip of your scalpel all the way down so that we can open it up kind of like a book. Okay, so you see the spinal cord, you'll see some vasculature on top of the spinal cord. I'm going to pull this back now. The next meninge layer is your arachnoid. Okay, so I'm going to pull it up. You might see that little, it's almost like saran wrap. You can usually separate it from the spinal cord, and now I'm in the subarachnoid space. Okay, the last layer, the pia mater, is pretty much indistinguishable, and it's right on top of the surface of the spinal cord. Okay. Okay, a couple more things. When you open this up, I want you to take a little bit of time looking for what looks like, if you were to grab that arachnoid, pinch it together, and it's attaching to the inside of the dura mater. And so you can see parts where it's almost like it's anchoring the spinal cord to the dura, okay? And that's called your denticulate ligaments, and you'll have them all throughout, okay? And this is so that the spinal cord isn't shifting and pinching those nerve roots as they exit. If you were to bend over, it stays pretty anchored to that dura mater, okay? All right, I'm gonna move inferiorly. Yours is going to be much lower. This was a very difficult laminectomy here, so I didn't take it down, but I'll show you another one in just a second. But you're going to follow it until you see it end in a cone-like structure. And it's right about here. we have our conus medullaris. Okay, I know that because I can start to see that cauda equina. I'm picking it up on this side. I think it's a little bit difficult to see.
Yeah.
Where we have a bunch of these inferior nerve roots spanning off of the spinal cord. Okay. All right, so I'm going to shift over to, we're going to shift over to the other camera because the last structure that you want to look for, and you got to make sure that you you remove the spinal column low enough, but it's this structure of dura that is attached to the conus medullaris. Is it not on? Oh, hold on one second. I think the camera turned off. Oh. Looks like it was.
Okay, folks, just wait. Can you give us a few seconds? We're trying to fix the camera. We'll be back.
So once you find the conus medullaris, you're going to look for something that looks similar to oh, here, let's slide this in a little bit. Is that good? Okay. Looks similar, and this is our phylum terminal internum. Okay, I'm going to separate this out. Okay. Oh, okay, all right, so I'm lifting it up here. You can see how it's attached to the very tip of the spinal cord right here, the conus medullaris. This is going, the phylum terminal internum is going to descend, go through the sacral hiatus and attach to the coccyx. Okay, sort of anchoring the spinal cord also in place. Okay. All right, so take a moment to see that as well.
Can you show a nice DRG? That's
Oh, just taking a look at another DRG right here superiorly.
Oh,
that one's cut
no,
right here.
this one.
Yeah, that one.
This one.
Yeah.
Okay, so if I look at this, you see it's real thin and it gets like a ball, almost like if you were to ball up the nerve.
Mhm.
Okay. All right, I think that's it. I think that's everything. So we'll see you here in the lab and let us know if you have any questions.
Okay, divide and conquer in your groups. Some of you are working low, some of you are working on suboccipital, some of you are getting ready for the laminectomy, all right?